Good morning, everybody. My name is Aman Chauhan. I'm a medical oncologist, and I lead our neuroendocrine cancer program at University of Miami. I co-direct our theranostics drug development program at Sylvester Comprehensive Cancer Center. Thank you to NETRF for giving me this wonderful opportunity to interact with your audience and describe the basics, the nuts and bolts of neuroendocrine cancers. Later today, you are in a treat for dedicated lectures by specialists in different aspects of neuroendocrine cancer management. But before we go there, we felt that it'll be interesting to get a primer in for neuroendocrine cancer so you can familiarize yourself with various terminologies. How do we approach neuroendocrine cancers? And let's get going. So why do we need to study neuroendocrine cancers? Unlike most of the common cancers in the United States, colon cancer, lung cancer, breast cancer, their incidence have plateaued, if at all, maybe slightly decreased, which is great news. But neuroendocrine cancers are on a steep incline. This is unpublished data, the most recent SEER data, which suggests that the current incidence of neuroendocrine cancer is about 8 in 100,000. This used to be 1 in 100,000 in 1970. So we have seen about 8-fold increase in the incidence of neuroendocrine cancer, while all other major cancers have plateaued or are declining. So that's worrisome. Moreover, a lot of neuroendocrine cancer patients live for months, years, and decades. It's a chronic indolent disease. So the cumulative prevalence, that means the number of patients alive with the diagnosis of neuroendocrine cancer, are significantly larger than its incidence. You'd be surprised to know that in the United States, there are well over 170,000 patients with a diagnosis of neuroendocrine cancer, putting neuroendocrine cancer of GI origin among one of the top prevalent GI malignancies. So this is really important to understand the growing burden of this disease, not only in the US, but globally. And that's why we need to understand how to diagnose and then later manage neuroendocrine cancers. One of the uniqueness of neuroendocrine cancers is that it's not a single disease. It's a spectrum of disease. In this slide, I've kind of laid out the spectrum of disease of neuroendocrine cancer from low-grade, well-differentiated neuroendocrine tumor, also known as carcinoid tumor, on one end of the spectrum, to poorly differentiated, high-grade neuroendocrine carcinoma, very aggressive end of the spectrum. You've all heard about Steve Jobs, the inventor of iPhones. We unfortunately lost Mr. Jobs to pancreatic, well-differentiated neuroendocrine tumor. On the other end of spectrum, you probably heard of Irfan Khan, one of my favorite actors. He was in Life of Pi. We lost him to a poorly differentiated neuroendocrine carcinoma, very aggressive variety of neuroendocrine cancer. And also based on the organ site, sometimes the names could be different, although they imply the same thing. For example, lung neuroendocrine cancers are often defined as typical carcinoid, atypical carcinoid, and on the aggressive end of spectrum, small cell lung cancer and large cell neuroendocrine carcinoma. I put these terminologies on side by side, basically implying the same thing but in different languages. So typical and atypical carcinoids are well-differentiated neuroendocrine tumors of higher grades, from typical to atypical, from lower grade to higher grade. And then poorly differentiated neuroendocrine carcinoma of GI tract or extrathoracic origin are the small cell and large cell neuroendocrine carcinoma of the lung. So they are basically implying the same thing. For our clarity, I like to bucket them into two major categories. So whenever I have a patient, especially during their initial visit, I like to simplify the disease for them and try to categorize my patient into one of these two major categories. This is the first dichotomy. Am I dealing with a neuroendocrine tumor patient, NET, or a neuroendocrine carcinoma patient, NEC? This T and C is very crucial. They are day and night different in terms of how we diagnose them, how we manage them, and the overall prognosis and outcome. Neuroendocrine tumor are of further 3 types based on their grade. Grade is something that we figure out by looking at these tumors by our naked eyes under the microscope. And we have two techniques. Either we count the mitotic index or Ki67. Ki67 is a brown dye. I'll show you in a second. And higher the uptake with Ki67, the higher the grade of the tumor. Let's study about the pathology. I think this is by far the most crucial aspect of neuroendocrine cancer. If we get the pathology wrong, we will get the entire management wrong. So these pathology friends are the unsung heroes who are behind the scene but are really contributing towards the most important facet of the management of neuroendocrine cancers. So neuroendocrine tumor, the well-differentiated neuroendocrine tumor, this is how they look under the microscope. And the slide in the center, the bluish colored slide with the brown dots, are the Ki67 marker. And as you can see, most of the slides not actually stained by the Ki67. So the Ki67 index is low. If it's under 3%, these tumors would be classified grade 1, 3 to 20% grade 2, and higher than 20% grade 3 for well-differentiated neuroendocrine tumor. Let's take a look at the neuroendocrine carcinomas and how do they look under the microscope. So the first difference, the stark difference you'll see in the center slide, the Ki67 slide. Unlike the previous slide where there were very few cells staining positive for Ki67 dye, here most of the slide is brown. That's the very high Ki67, probably 90% or higher. This is very emblematic of high-grade, poorly differentiated neuroendocrine carcinoma. And if you remember, there are two types of poorly differentiated neuroendocrine carcinoma, the small cell and the large cell. You can probably also figure out on the right hand of the side, those are the large cell poorly differentiated neuroendocrine carcinoma. On the left hand side is the small cell, small round blue cells. So those are morphologic classifications or how they look under the microscope. This distinction is utterly critical for us to understand what we're dealing with so that we can put in the right management in place. You may ask, why do we have to know about this finer nuances of are we dealing with NET or NEC? Well, look at the survival data or the outcome of how these distinct diseases do. On the top, the black line is the outcomes of well-differentiated neuroendocrine tumor, especially the lower grades. And these patients, you see, the median survival is in several months to years. Perhaps even some patients survive decades. As compared to a well-differentiated grade 3, which is the blue line, clearly more aggressive than the grade 1 and grade 2, and the median survival is significantly shorter than the grade 1 and grade 2. But as compared to the red line, which is poorly differentiated neuroendocrine carcinoma or NEC, that's where we see the survival statistics are very, very poor. The median survival may be about a year to year and a half. Because the outcomes are so distinct, that tells us there are distinct biologies, that there are distinct cancers, and they need to be managed in a distinctive way. That's why it's very important for us to understand what we are dealing with, NET or NEC. And if it is NET, what variety of NET, grade 1, grade 2, or grade 3. Let's move a little bit further. So far, we figured out that these tumors, NET or NEC, they are different when we look at them under the microscope through our naked eyes. They're also different cancers in terms of their biology and the outcomes. But not only that, we now know there are different cancers in terms of their pathophysiology. So Memorial Sloan Kettering, our colleagues there, Dr. Reedy, Dr. Tang, they studied the molecular underpinnings of these cancers and sequenced and did genetic testing on these cases. And what they figured out that the mutational patterns of an NEC or a poorly differentiated neuroendocrine carcinoma is very distinct for a very differentiated neuroendocrine tumor. For example, in NECs, you will typically find TP53 mutation or loss of RB1 as compared to well-differentiated neuroendocrine tumor where you will find mutations in DAX, ATRX, etc. So even the grade 3 well-differentiated neuroendocrine tumor, which is a higher grade tumor, is distinct than poorly differentiated neuroendocrine carcinoma. So to summarize this segment of the talk, ask about your pathology at your first visit. Very important to have a clear understanding, are we dealing with NET or NEC? If it's an NET, ask your doctor, what is my Ki-67 or my thyroid index? And I highly encourage patients and the caregivers to get their pathology reviewed at high volume centers. It's extremely challenging. Some of the cases could be very difficult to diagnose, and there's plenty of data in the literature that two pathologists can often disagree in terms of grading and even diagnosis. So it doesn't hurt to get a specialized opinion from a high volume net center. Let's move on to the next phase of our discussion. So when I am meeting a new patient and I'm explaining them and really demystifying the disease for them, once we've taken care of the pathology aspect, the next step is to find the origin of the tumor. Neuroendocrine cancers can really originate from many parts of the body. NETs, the commonest site by far is midgut or small bowel, small intestines. Pancreatic nets probably are the second most commoner site, followed by the lung nets. But these are not the only places they can originate. Appendix, rectum, breast, ovaries, you name it. I even recently saw a couple of cases from middle ear neuroendocrine tumor, well differentiated. However, by far, majority of our patients would belong to one of these three categories. Neuroendocrine tumors can also be seen in pediatric age. Fortunately, majority of neuroendocrine tumors in pediatrics are seen in appendix, and they're often caught early, and patient presents with appendicitis and are resected, and majority of patients are cured. However, outside appendix, lung nets have been described in pediatric patients, and the other organs are extremely rare. Let's also review the site of origin for NECs. It's very difficult to really condense NETs and NECs in one talk. However, I'll try my best to run these things in parallel at a very high level so you can understand basics of both the disease. NECs are primarily found in your lung. We broadly classify them into thoracic or extrathoracic. Within lung, small cell lung cancer is by far the commonest variety of neuroendocrine carcinoma, NEC, but they can also occur outside lung. For example, breast, GI organs, colon, large cell neuroendocrine carcinoma, pancreatic, large cell neuroendocrine carcinoma, gallbladder, large cell neuroendocrine carcinoma, ovarian, large cell neuroendocrine carcinoma, cervical, small cell carcinoma, prostate, small cell carcinoma. So, multitude of organ systems can be afflicted with high-grade neuroendocrine cancers. The common thread between all of these types of high-grade neuroendocrine carcinomas is that they are all very aggressive with rapid doubling time. The doubling time can be as small as 2 weeks. So there's a sense of urgency in managing high-grade neuroendocrine carcinomas. Since small cell lung cancer by far forms the majority of NECs, let's look at the lung cancers and the representation of small cell lung cancer in all lung cancers. So this is a SEER database review of all thoracic cancers. And as you can see, neuroendocrine cancer of thoracic origin or lung origin form roughly about 14 to 15% of all lung cancers. Out of that, vast majority, about 12%, are small cell lung cancers. And others, about 4%, represents the rarer subtypes, the typical carcinoid, the atypical carcinoid, and the large cell neuroendocrine carcinomas. Let's get to the next level of classification for neuroendocrine cancers. You all thought it would be easy, right? We're just getting started. So we talked about the morphology, the net versus neck. We talked about the site of origin, the pancreatic net versus lung small cell versus other extrathoracic high grade. There is another way to classify neuroendocrine cancers, and this is specifically for NETs, not for NECs. A small subset of NET patients can secrete a hormone or a vasoactive peptides, roughly about 20 to 30% of NETs. And based on what are hormones they are secreting, patient can exhibit certain specific symptoms. By far, the commonest hormone is serotonin, and you've heard of a condition called carcinoid syndrome. It's a condition where a well-differentiated neuroendocrine tumor, usually of midgut or small bowel origin, some lung neuroendocrine tumors can also secrete serotonin. They'll secrete serotonin, and that will give carcinoid syndrome, flushing, wheezing, diarrhea, muscle aches, rashes, mood disturbances, fatigue, multitude of effects. However, that's not the only hormone. Pancreatic neuroendocrine tumors can secrete vasoactive intestinal peptides, VIP. These patients can have enormous amount of diarrhea, 10, 15, 20 stools a day. Certain NET patients can secrete excessive gastrin, giving a condition called Zollinger-Ellison syndrome, peptic ulcer disease. Some pancreatic NETs can secrete too much of insulin and have really low blood sugar. So the patient will give you clues that, doc, I'm having blurry vision, shakiness, my sugar's low. And that kind of history can be seen with insulinoma cases. So these are some of the commonly found hormones in functional NETs. However, have we discovered all of them? Probably not. Some are yet to be discovered. By far, majority of NET patients are non-functional. That means they will not secrete these vasoactive amines and will not have these symptoms. However, they can still be symptomatic from the tumor burden, or what we call mass effect. If the tumor mass in the liver is pressing on the stomach and patients having dyspepsia, having difficulty in eating and early satiety, etc. But this is another classification important to know in the initial part of workup for neuroendocrine tumor patient, whether the patient is functional or non-functional. So do ask your provider, hey doc, am I a functional NET patient or a non-functional NET patient? Because this might have certain implications. What are those? For example, patient with carcinoid syndrome who have high serotonin level, these tumors are secreting serotonin. We know from the literature, patient with exceptionally high serotonin can have shorter survival. And why would that be? High levels of serotonin are very corrosive to heart. They can damage the heart valves and give a condition called carcinoid heart disease. They're also not easy on your gut. They cause fibrosis around your intestines and cause mesenteric fibrosis, a difficult disease to treat. So it's always better to detect serotonin levels, monitor them, and strive to lower them, not only to improve the symptoms, but also improve the outcomes and prevent these complications from elevated serotonin. Also, we have ways to target serotonin, not only secretion of serotonin with help of drugs like sandostatin and lanreotide, which blocks to the somatostatin receptors and reduces the secretion of serotonin. We now also have drugs like Zermelo, telitrestat ethyl, which blocks the production of serotonin and is now FDA approved for management of carcinoid syndrome diarrhea refractory to somatostatin analog. So understanding whether we are dealing with a functional or a non-functional patient has a lot of implications in terms of outcomes and management. Those are the two targets. One of the somatostatin analog target, and the one is target for Zermelo, which inhibits the production of serotonin inside neuroendocrine tumor cells. So to summarize, it's really important for us to understand the NET versus NEC. In this slide, we can see for a NET patient, we'll often use some somatostatin receptor imaging like gallium dotatate, copper dotatate, as compared to NEC, which are more aggressive patient and would be better suited for a FDG PET instead. A low-grade NET patient might get treated with somatostatin analogs like sandostatin and lanreotide, whereas the high-grade neuroendocrine carcinoma will often be treated with stronger IV chemotherapies like cisplatin or carboplatin etoposide. I would not go into the finer nuances of management, and we have lectures later today that will explain these nuances. However, the big picture thing is to get the diagnosis right, because once we get the diagnosis right, we will then employ the right type of diagnostic imaging, the blood tests, as well as the treatment regimens. This is a good segue to diagnostics. We have kind of sort of understood the basics, terminologies of neuroendocrine cancers and distinctions of different subtypes. How do we diagnose neuroendocrine tumors? If we don't suspect it, we don't detect it. You probably heard that neuroendocrine cancer patients are often misdiagnosed, or there is a significant lag in diagnosis. Why is that? One of the reasons is either the neuroendocrine tumor patient is asymptomatic for years because it's a low-growing cancer, or the symptoms might mimic various common medical conditions. So if somebody is having carcinoid flushing, they might be mistaken for an allergic or a mast cell disorder disease or a hormone imbalance, perimenopausal symptoms. If somebody is having diarrhea from VIPoma, they might be misdiagnosed as having inflammatory bowel disease or a celiac disease or some sort of other GI condition. So it's not uncommon for our patients to see several providers before somebody establishes a diagnosis of neuroendocrine cancer. Back in the day, Dr. Ramirez and I reviewed a rare subtype of neuroendocrine cancers called DIPNISH, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, sort of like a precursor condition to lung mets. And what we noted that all of our patients were either diagnosed with asthma or allergy or COPD for several years before somebody figured out that this is DIPNISH. So just to kind of showcase that this problem of delay in diagnosis is real. Once a diagnosis is established and we found out the tumor on a scan or a colonoscopy or endoscopy, and we did a tissue sampling, and we have a confirmation for our pathologist, we're dealing with NET or NEC, the next step is usually blood test. Unfortunately, the blood-based tests for neuroendocrine cancers are not very accurate. However, there still is role. Chromogranin A, the recent consensus recommendation is to avoid overuse or consistent use of chromogranin A because it's not very accurate. You might have a high chromogranin A and no tumor, or low chromogranin A and high tumor burden. So it doesn't really represent the tumor status very well. Having said that, if we are dealing with a functional neuroendocrine cancer patient, for example, insulinoma patient, or a VIPoma patient, or carcinoid syndrome patient, there's absolute great value in checking for the respective hormone levels so that we can understand what is the baseline for that patient and how is that patient responding to the treatment, because our eventual goal is to normalize these hormones. As far as the diagnostic tests are concerned, NET test is definitely far superior as compared to chromogranin A or several of other diagnostic blood-based tests with sensitivity and specificity well over 90%, and it's published in several papers. So there's definitely some strides when it comes to blood-based biomarker for diagnosis and monitoring. We ourselves are studying new forms of blood-based tests to understand, can we detect and monitor these cancers with just a simple blood test and not completely rely on imaging. And these tests are currently being evaluated in several clinical trials. So this is just to kind of show our audience that we are working. We might be, this might not be a perfect science, but we are working towards finding a better solution for monitoring problem. Where we have made significant strides in terms of improving our diagnostic capabilities are in molecular imaging. On the left-hand side, you can see OctreoScan. So it was a great scan for its time. And this scan used to detect somatostatin receptor positive disease. We have now moved to the era of dotatate imaging, a far superior, more sensitive way to detect somatostatin receptor positive neuroendocrine tumor. As you can see, same patient, but you can very clearly see individual distinctive lesions within the liver as well as outside the liver. These scans are so superior that we can detect lesions as small as 3 millimeters sometimes, especially if they're outside your usual areas in hiding the bone or some lymph nodes. They're very, very useful to detect these obscure areas. Based on significant sensitivities and specificities over the previous standard of care, these scans are now FDA approved. The first one was the gallium-68 dotatate scan, or NetSpot. Recently, DetectNet, the copper-64 dotatate, and now there are others as well. So more the merrier. We have multiple choices to offer to our patient. These scans are just phenomenal, and there is really no reason in the current day and age to get the old school octrio scan. You will miss a lot of disease if you don't pick the more recent, don't take PET images as compared to the older octrio scans. All right. So we've now reviewed how we classify the cancers, what are different terminologies, different ways of grouping the patients based on the site of origin, based on whether they're producing a hormone, functional NETs versus non-functional. Let's talk a little bit overview of management. That's the final step. That's where the oncologists take the lead. So a good oncologist will synthesize all this data and come up with a roadmap regarding what is the best treatment option for the patient. For an early stage cancer, that means stage 1, 2, 3, surgery by far is the best choice and offers a potential cure. So if the cancer is caught early, for example, pancreatic NET, it's still in pancreas, or a small bowel NET, still in the small bowel, and maybe some lymph node involvement, still early stage, no evidence of distant metastatic disease in another organ like liver or bones. The goal is always to strive for a cure, and surgery is the only way to do it. However, for patients who cannot get surgery for either medical reasons or outside the purview of this discussion, certainly we can treat them using other modalities, including systemic therapies and in certain select case radiation. For metastatic cancers with stage 4 disease, that means the cancer has already spread to various organs. It is not possible to achieve cure, unfortunately. However, we have fantastic treatment options, and we can certainly make this disease into a chronic manageable disease, especially for NETs. In the recent years, especially over last decade, we have made huge strides in terms of advancing our treatment options. Look at all the approved treatments. Cabozantinib is not FDA approved yet, but was found to be very superior to control arm in cabinet study, recently concluded cabinet study. These are all important treatments currently used as standard of care in different subsets of neuroendocrine tumor patients. This is a big contrast to when I started in this field, where there were times where we used to send patients to Europe to get PRRT. We didn't have a lot of good options. Now the problem is problem of plenty, which is a good problem to have. How do we sequence these treatments once patients has progressed on somatostatin analog? Should somebody get Captem or cabozantinib or PRRT or everolimus or sunitinib? These are difficult conundrums, and we will try to demystify them over the next several years with help of different clinical trials. This is one of the papers where me and my colleagues, we try to brainstorm how to simplify these sequencing strategies. It's not easy. That's why a multidisciplinary NET tumor board discussion is highly recommended, especially if it's not a straightforward case. There could be role for liver-directed therapy if it's a liver-dominant disease. There could also be role for debulking cytoreductive surgeries or selective ablations. You've recently heard about histotripsies and other modalities. So besides systemic options, there are other ways to manage neuroendocrine tumor patients. And that's why seeking a consult with a high volume NET center is not a bad idea. To conclude the talk, let's focus last couple of minutes on NECs. As you know, NECs can happen anywhere in the body, but by far, small cell lung cancer represents majorities of NECs. And they are primarily of two major subtypes, small cell or large cell. But they are both very much similar, almost like sister cancers in terms of prognosis and outcomes. So they're treated somewhat similarly. Look at the outcomes or survival outcomes for small cell lung cancer. It's in months to a year and a half. We definitely have a lot of catching up to do with our non-small cell lung cancer colleagues. How do we treat high-grade neuroendocrine carcinoma? We take a lot of learning from small cell lung cancer data and extrapolate it, and then use those treatment modalities for extrathoracic NECs. Platinum-based doublet, the carboplatin etoposide and cisplatin etoposide, has been there for years, really since the 1980s, and are the mainstay of the treatment for the frontline management. In recent years, we have learned that if you add immunotherapy to the mix of chemotherapy with platinum-based doublet, the patients do a little bit better In past, before the immunotherapy, 5-year survivals were about 7 to 8%. Now we have 12% survival. So there is slight improvement in the era of immunotherapy, but this is not where we want to be. We want to see a significant improvement beyond this. Second-line options do exist for high-grade neuroendocrine cancers. I've listed a slew of chemotherapies. However, the benefit is very short-lasting. The cancer becomes extremely aggressive after platinum resistance, and we have not understood why that is. Very recently, maybe about 2 weeks back, a new drug was FDA approved called tarlatamab, which is a DLL3 BiTE or bispecific T-cell engager antibody, and seems to be very promising for small cell lung cancer. It's currently being investigated in extrathoracic high-grade neuroendocrine cancer. So the treatment options are definitely improving, but not at the same pace as we are seeing in NETs. A lot is desired. Ipi-Nivo is a doublet of immunotherapy, immune checkpoint inhibitor, was tested in a smaller national study called SWOG-DART 1609 and did report some promising outcome. This is one of my own patients with poorly differentiated neuroendocrine carcinoma having a complete response after Ipi-Nivo. However, these are smaller studies, and in real world, very few patients benefit. However, those who do benefit show remarkable, deep, durable responses. Some of the factors to consider while applying immunotherapy in your practice for NECs might be TMBs and MSI status. However, they're not specifically validated in neuroendocrine carcinoma population. We are at Sylvester Comprehensive Cancer Center trying to build on the success of Ipi-Nivo and combine a bioengineered oncolytic virus, which have tropism for high-grade neuroendocrine cancers like small cell lung cancers. And very soon you will be seeing this first-in-human clinical trial for NECs, which is a critical unmet need. Some of the other promising ways to treat NECs are using radiopharmaceuticals. Now, PRRT is mainstream treatment for NETs, but could there be a role in NECs? We do know a small subset of NEC patients can express somatostatin receptors. And there are some pilot studies that have evaluated targeting SSTR with help of lutetium-based radiopharmaceuticals with some data to suggest there could be activity. So in near future, you will see not one, but multiple clinical trials testing both beta and alpha PRRT in high-grade NEC space with various targets, not just somatostatin receptors. You might see DLL3, fibroblast activating protein, integrins, and many others. So I like to conclude the presentation by saying that NECs and small cell lung cancers, they're very aggressive disease. They are oftentimes present with metastatic disease. For the frontline management, chemotherapy with immunotherapy does have high success rate, but these cancers often recur very fast. And second and third line options historically don't have good results. Recently, DLL3 BiTE antibody seems extremely promising. However, new targets, new drugs needs to be developed for this critical unmet of the disease. With that, I'd like to conclude our presentation. Thank you again, NETRF, for giving me this opportunity to go over the nuts and bolts of neuroendocrine tumors and neuroendocrine carcinomas. I do have to give a disclaimer. Each aspect of the neuroendocrine tumor and neuroendocrine carcinoma we discussed today can be described in a whole dedicated lecture of its own. So it's very difficult to summarize all the nuances, but I hope you got a very broad overview of terminologies and concepts with neuroendocrine cancers. And I can promise you for the rest of the day, you are in for a treat by my colleagues where they will go and take a deep dive into different facets of neuroendocrine cancers. Again, thank you for joining us. Till we meet again.